so I think we're going to start because I have additional meeting after this one. So welcome to our new 2024 continuation of the Stat series. And happy new year to all of us. So well, I just do a little cap on what we did before. So previous year we had 2 lunch and learn series. They were more general about the data and about philosophy of statistics. And after that we had 3 lectures related to p-values, distribution, and different statistical measures like rates, prevalence or incidence, and all those lectures are available online if you would like to hear them. And if you listen to them and have any question for any of the lectures, in statistical service page you have my email and my contact information, so you can send me an email and meet with me to discuss your question. So today's lecture is the comprehensive insights, understanding the link between study design, statistical modeling, and analytical applications. So I have this question a lot because people ask me, oh, which study, when they write in the paper, they ask, oh, which study design was it cross-sectional, was it cohort, what it was. So I thought to do this lecture because I think understanding your study design and what you want to do is very important. It's also very important to know what is your research question and link between your research question and a proper study design, because the way you design your study will affect how you recruit people, how you contact people, what information you're going to gather from people, what data gathering, like tools you're going to use, like survey, you can use admin data and so on. So it's very important. And like in my experience, had a lot of situation when people wanted to do a great job, but actually their study design was not perfect, and it was really hard to do like really good research paper or research analysis out of the wrong study design. You sometimes can do it, but it takes a lot of time to figure out what's the best way to do it. So objectives for today's series will be understanding the diverse palette of study designs, and each study design is related to specific statistical modeling. So we're going to talk how those related, and we explore the connection between different statistical techniques and analytical observations and applications, and also understand connection between them. What is study design? So basically, classical definition of study design, it refers to the framework or plan created to conduct a research study or investigation. It outlines the structure, method, and procedures that will be employed to collect and analyze data to answer our specific question and test our hypothesis. A well-designed study takes into consideration factors such as type of research, the population or sample being studied, the variables we will going to use, and the major goals of our research. We can slightly simplify it and say study design is basically our plan for research investigation, and we need to understand, we need to have clear research question or set up hypothesis clearly, one or multiple. We need to decide what type of research we're doing. We need to identify time frame, time period we're going to collect our data. We need to understand our target population, because like if you're doing analysis on cervical cancer, we will have some restriction of population we're going to recruit. And we also need to identify the important factors that can be translated to variables, or I usually call them outcomes. So for example, if you're doing survey questions, we need to design questions in such a way that it will be really easy for us later to transfer them to variables that can be used into analysis. So basically for our study design, before we're doing any collection of information and deciding which analysis we're going to do, we need to understand all this and think through about all those details, so we have a good research after that. So here I put some flow charts about study design. One I took from somewhere online, another one I created. So basically they show similar information. So the main goal of any study design is define our research question. After we know what we want to study, we need to choose appropriate study design to answer our questions. And study design are divided to two major groups. And we're not going to do, there is a lot of different study design, many of them, but we're going to talk today all mostly used in health research, not all of them. So we have experimental design and observational design, or non-experimental design. Experimental design is usually something when we randomly assign people, or we have quasi-experimental design, because it's sometimes very expensive to divide people randomly to group, or ethically it's impossible. This way we can set up experiments that would look like randomization, but actually would be not. But we're not going to talk about quasi-experimental design today. Also, it can be systematic review or meta-analysis, but because I'm not expert in this area, there's not much I can add about it, but you can, if it's of interest, you can review it later. And for observational study, it's mostly the study we use in health research. It's cohort study, case control study, cross-sectional study, and case reports. Those are four major, those are our major, those are major studies. Yeah, for example, here on the right, you also see ecological design. As I'm not expert of this type of design, I'm not going to talk about it a lot, but if someone wants, I can investigate in more details what it is. I know about both of them in general, but it's not my area of expertise right now. So study design, the time frame. So when we are asking our research question, we need to understand, are we asking this question retrospectively or prospectively? Are we asking this question in one specific time point, or are we going to look on the study longitudinally and follow up people for a long time? So two studies that measuring something usually in one point of time, it's cross-sectional study and case study, and cohort study, it's usually longitudinal. So you have prospective cohort where you recruit people and looking for their outcomes, exposure, different variables in the future, or retrospective cohort where you already collected the information and you're trying to figure out what happened. So the first study design is case study design. I'm not going to talk a lot about it. Basically, this is one of the simplest but also most comprehensive study design. Usually in medicine, it's used when we want to talk about specific case, like specific patient with interesting results or story, or something where, or specific population we're going to, specific like small subgroup we want to evaluate. We're not doing usually a lot of statistical analysis, but we're describing the story about this patient or group. So case study is a deep study of one person, group, or event. Almost every aspect of subject life and history is analyzed to seek patterns and causes of behavior. It's usually applied in psychology, medicine, sometimes education, anthropology. You can do it for political science or social work. The purpose of case study is to learn as much as possible about a specific individual or a group, and so that the information can be generalized to many others. However, some of the case studies tend to be highly subjective, and it's usually very hard to do direct relationship for the larger population, but those are can be very interesting as start point to understand where we want to go further to investigate maybe larger group. So this is basically, I put down in blue, this is references for the paper I took the information from. So basically, I think the paper from BCM Medical Research Methodology has very good description of what is case study. The illustrative ground round, so usually like, in healthcare, we have ground rounds when we describe in specific patients. So The illustrative grant rounds case reports of case series have a long tradition in clinical practice and research. Presenting detailed critique, typically of one of my patients, aims to provide insight into aspects of the clinical case, and it's doing so illustrate broader lessons that may be learned. In research, the conceptually related case study approach can be used, for example, to describe in detail a patient episode of care, explore professional attitude to any experience on new policy or initiative, and development, and more generally to investigate contemporary phenomena within real life context. So basically, it's how they define the case design study in the specific paper. And also additional paper, I just put the table from the paper, it's example of case studies. So example of case study investigating the reason for differences in recruitment rates in minority ethnic people in asthma research. So they saw that there is like less people from minority ethnicity groups are represented, and they collected the information to answer this question. So they report what is the context of the research and objective. For them, objective was to investigate approaches to bolster recruitment of South Asians into UK asthma studies through qualitative research. Yeah, and they explain in a lot of details how it was done. So next study design is the study design actually I'm very familiar with, and we're doing this type of study design a lot. This is the cross-sectional study design. Yeah, so basically on the left side you can see the picture. So we have population, we have snapshot of population in one specific time point. There is more complicated study design that we'll call cross-sectional, when we actually do two snapshots of the population and we comparing them. For example, I had this study for HIV positive and negative women where we tried to answer the question about comorbidities, if there is a difference in comorbidities. Actually, it was cohort study design, but because we didn't have in the beginning all the longitudinal data ready, we looked on this population at baseline and we look on this population at last available survey, and we compare 2 points to see the dynamics and changes. But we didn't use longitudinal analysis here, only comparison on two specific snapshots, beginning and end. So cross-sectional study are in observational studies that analyze data from a population and single time point. They often used to measure the prevalence of health outcomes, understanding determinants of health, or describe features of the population. So I took some of the example from the specific paper about strengths and weaknesses of study design. So here from cross-sectional study, you see the flow chart of how it can be done. So we have target population. If we cannot study the population, we're going to do or choose a study sample. We can sample it, or if we don't have a ability to sample, we can take our registry or subpopulations that we have. We gather the data from those people in one point of time on both exposure and outcome. So both exposure and outcome are measured usually in same time point. And our group will be defined for those exposed and unexposed with or without outcomes. So basically, this is the basic classical design for cross-sectional design. So the strength of this design is that it's relatively quick and inexpensive because we don't follow people for a long time. Usually there is no ethical implication. Data on all variables are only collected in one time point. Multiple outcomes and exposures can be studied. So for example, we can have our main goal for our research with main exposure and outcome, but because we collected a lot of information, we can look on secondary objective of sub-analysis from the same data collected to answer additional questions. Multiple outcomes and exposures can be studied. It's easy to generate hypotheses based on the study design, and many findings can be used to create in-depth research studies. So actually it's very simple, but you can do a lot of things with this. So the weaknesses, we cannot measure incidence. If you listen to my previous lecture, we talked about incidence and prevalence. So prevalence, it's all possible conditions, like we're measuring a specific disease for population and specific time points, when incidence actually are the calculations of only new cases. Yes, so based on cross-sectional study design, you cannot calculate incidence, only prevalence of something in the population. It's difficult to make causal inference from the case study design, but actually it's very hard to do from all observational studies, and I'm going to talk about it a bit later. It's sometimes hard to identify the association between different, like between outcome, exposure, and possible covariates. We cannot investigate temporal relations because we're not following people over the time, and we cannot do it for outcomes and risk factors. It's hard to study rare disease based on the study design, and if we're doing like a snapshot survey, we can be exposed for non-response bias or recall bias, but it's true for all other study designs, observational study designs as well. So next study design I'm going to talk about is case control study design. So basically, it's a bit different from the cross-sectional study design because we're measuring exposure and outcome a little bit different. So again, this is a type of observational study. Participants are selected for the study based on their outcome status. So we in classical case control study, we divide people that have outcome and don't have outcome. Cases are participants with the outcome of interest, and controls are patients that didn't have outcome of interest. And we're trying to access exposure in both groups. So this is the difference between case control study and cross-sectional, because exposure and outcome are kind of on opposite places. And here you can see the like really small diagram showing how the case control study works, and here's this reference from the paper. So strengths and weaknesses about case control study. Fast to conduct, it's not expensive because we doing it at one point of time. We can use this to study rare outcomes. We can use it again to study multiple exposures, and useful to study the association of risk factors and outcome in like outbreak. When you have outbreak, it's very useful to do case control study because we know people with outcome and without. So again, we can do it for rare outcomes, but again, it's not useful to study rare exposure. Again, because it's we measuring something at one point, we cannot estimate the incidence. And usually for case control study, based on my experience, the most models that we're going to use is logistic regression. Most of case control studies use logistic regression because we have outcome yes or no. We can have like a categorical or 1-0 exposure, and we have different covariates. So when you do case control study design, it's very important to match your cases and controls because those should be kind of comparable group. You want to stratify them correctly so it's easy for you to look at the exposure. So why are we doing matching? Because matching in case control study prevents efficiency loss by aligning cases and controls in terms of key risk factors distribution. It reduces the chance of significant differences between two populations based on crucial risk factors. Matching should be considered only for risk factors which confounding effects need to be controlled. Yeah, so usually it's like if you want to match cases in control, usually we're going to match them by sex, gender, race, age, but we're not going to match them based on exposure and other covariates. Usually it's social demographic characteristic. Matching of variables that are unrelated to risk of disease is pointless and can reduce the study efficiency. So basically, for example, any study I do, I always, if it's not case control study, I always will adjust for like basics, the social demographic characteristics, even if they not significant in an adjusted model. Yeah, and here it's kind of the same idea. We want to match them by, it's least by age, sex, race, or some other characteristics that are relevant to our sample. And basically here is small diagram how you match. You have people that exposed and unexposed, and you matching them. You have unexposed and exposed people, and cases are you people with the outcome and controls people without outcome, and you trying to compare them. Forms of matching. They're probably a lot different, like you can do nested matching and other like types of matching, but for which one I did through my research career, it's usually is the individual matching or frequency quota matching. So individual matching usually done based on greedy algorithms. So basically it's a simple algorithm that compare people with the same characteristic. And for example, if I want to do case control matching as 1 to 5, it is going to pick up first best match people for first case and so on. So basically your probability of having a good match as for like people in the end of your matching, it looks like it can be reduced, but if you build the grading algorithm correctly, it's usually not going to happen. And frequency matching is when we want people from a different distribution. So basically we match them based on frequency. So for example, if there is 30% female and 70% male based on biological sex in our study, we would like to match the controls in the same proportions. So I can give you one example. So I did case control matching for the overdose cohort. So for example, for the general population, we decided to match based on 1 to 5 ratios, 1 case to 5 controls, and it worked very well. We matched based on age, race, and sex. Maybe there was some other characteristics, but those are the major. We allowed for age, it shouldn't be like, for example, 1 to 1. So for age, we allowed like plus minus 5 years difference by age for matching, and we did like it. I developed the greedy algorithm and it worked very well. But after that, we needed to replicate the same analysis for First Nations, and First Nations people were identified based on government, Ministry of Health client roster. And we only had flag for people that can be included in the analysis. So for example, because it's different structure of population and population has different distribution, the 1 to 5 case control matching was not working for us. And actually we ended up matching people 1 to 1. There is debate of how to match you cases and controls. So for example, for this specific cohort, we wanted first to do 1 to 10, but I did the extensive literature review and a lot of papers. I don't remember the names and I couldn't find, unfortunately, to put it on the slide. But basically, most of the papers or research said that 1 to 5, it's enough. If you can match for more than 1 to 5, but you're not gathering any additional information. So basically, this is the matching. So if you have analysis that you want to do matching, I can explain you in more detail about greedy or stratified frequency algorithms for matching. Now, the additional important study that we have, it's cohort study. And actually, this one is my favorite study. Cohort study design is not experimental. If type of non-experimental or observational study design, the participants do not have the outcome of interest to begin with, but we're following them up to see if they will have the outcome. The participants are selected based on the exposure status of individual, but it's only in classical cohort study design. I will give you examples when people actually in cohort are not recruited based on exposure status in the beginning. The participants are followed over the time to evaluate the occurrence of outcome of interest. So basically, cohort study is used if you want to measure incidence of something. Cohort study is a goal study design, because you not always include. Basically, you include kind of people without condition, or if you have larger cohort and do specific sub-analysis, you can restrict your cohort for people that didn't have outcome and longitudinally evaluate how long it's going to take them for occurrence of the specific outcome. And based on this study design, you actually can calculate the incidence. As I said before, some cohort studies do not include an exposure element as a starting point, but are instead created based on specific common characteristics. For example, like when we did like HPV vaccine study, I read several papers. Yeah, you take cohort of the girls that got HPV vaccine, and you following them up to look at the incidence of cervical cancers or incidence of HPV or warts or anything like this. So, and one of the cohorts I worked with this cohort in BC Center on Substance Use. It's called the ACE-CARE cohort to evaluate exposure to survival services, and we called it ACCESS. And this study involved individuals living with HIV who use illicit drugs and mostly living in Vancouver downtown East Side neighborhood. Researchers work with the participant to investigate how social, economic, physical, policy, and individual factors impact the health and well-being of those people. So we didn't divide those people based on specific exposures. So we restricted the sample for a specific group of population, mostly people that live in downtown side and have HIV and use illicit drugs, either injection or non-injection. But we're following those people to identify different behaviors or different changes. For this cohort, you can review, for example, if there was change in drug policy, or I don't know, we had introduction of inside like safe injection site. We can see how introduction of new policies or new environment can change behavior or health outcomes of those people. So this is this cohort. It's not necessarily the classical cohort when you have exposed and unexposed group. It's based on specific characteristics. So as I told in the beginning, types of cohort studies, we have prospective cohort study and retrospective cohort study. And the only difference between them is how we're looking for them in terms of time. So prospective cohort studies where we collect prospective data. So we look into the future. We define study population. We need exposure measurement. Participants in classical cohort study will be divided for exposed and unexposed. Ongoing data collection, so we recruited them at baseline and we were looking for them in the future, and we have surveys or like specific, I don't know, if it's radiology, we can do specific procedures and something like this. So we're following them up in the future. So, and when we have outcome, we can calculate outcome at one time or recurrent. For example, if you're looking for disease as HIV, it will be one time. For example, our cohort includes people that are HIV negative in baseline, and we're looking on them, not now, but for example, when there was pandemic in BC in HIV in early of the century, we can look on them and see like how many people had incidents of HIV. So this will be a one-time point outcome. But for example, if you're using for access as injection drug users, people can go to injection drugs, they cannot use drug for some time period, or they come back. So the behavior change over the time. So we can measure injection drug use as a recurrent event. And what is retrospective cohort study? Retrospective cohort study is data that already collected from the records. So usually for retrospective cohort studies, we're going to use, like we're using either survey we already collected or different administrative data that's collected by someone, and we putting them together and we're looking back in time on see historically what happened. So our outcomes occurred in the past, so outcomes already occurred. And study design remains the same. Investigator starts with exposure and variables at baseline and measure outcome during the follow-up. So basically, for this type of study, our baseline will be can be a long time ago. Like our baseline will be 96 when they recruit the cohort, and until now we're looking for them. For example, the access cohort I talked about, it's snowball design. So basically, people can enter into baseline in any time point. Yeah, so for some people, if someone recruited today, you can look for this person prospectively. But for someone that recruited in 96, you can look for this person up to date retrospectively. So this actually, all the cohorts I worked with in BC Center on Substance Use for kind of both, depends on the analysis you want to do. And also if researcher wanted to ask specific question, we can include a specific model to our survey questionnaire to investigate specific trait or specific area of interest. So basically here I put the same as I just said from Scribble. I put the pictures of prospective and retrospective cohort study. Yeah, when we are working on retrospective cohort, we usually develop the outcome. After that, we use an existing data and we comparing groups. For example, we looked who didn't have disease or had disease, and after that we compared them based on risk factor of exposure. If they, for example, we're looking in lung cancer, it will be smoker or non-smoker. And prospective cohort, we start in our research, we collecting the data on the go, and we're looking for all longitudinally, we are looking on different risk factors that will lead to our outcome. So now I'll give like more examples about cohorts. So again, as an example of retrospective cohort, I will be talking about provincial overdose cohort. So as you probably know, in April 2016, the BC ministry talked about overdose drug death emergency. So this cohort was developed a couple of years later to identify risk of overdose deaths in BC and see how the policies can be changed. So based on definition, this cohort included only linked administrative health data on people who had an overdose. And the cohort provided up-to-date information for provincial overdose response. So because it was administrative data, we needed to identify based on administrative data what will be the overdose case. Yeah, we need to define what it is because it can be a lot of different things. We also needed to identify additional important outcomes and algorithms for, say, co-injection drug users based on ICD-10 and 9 conspiracy from the health data, or what will be our definition of mental health and so on. So basically on the left in the picture, I don't know if you can see, this is all the administrative data we had. We had First Nation client file to identify patients for FNHA. We have social and development, poverty reduction, ministry and data on jail, from BC correction, and for health data, it was NACARS, emergency department, that administration, hospital, MSP, doctor's visit, and PharmaNet data is additional data to identify like which prescription drugs people use if they overdose on prescription drugs and so on. So, and the partners were PHSA, Ministry of Health, and different health authorities related to BCCTC. So when I started to work on this one, it was the first cohort. It went from 2015 and like to some, right now they have more data, but like last year they had till December 2020. And it's most administrative data. So we had overdose events, we have prescription, social assistance program information, mental health services use, incarceration history, health utilization, like we can measure how often people access hospitals and how often they access emergency department and what was the reason for access and all this information. And for all of those, we looked retrospectively, but also in addition to information we collected, we received historical 5 years data. So people that were included in cohort from January 1st, 2015, we had the medical data historically for them as baseline characteristic from 2010. So for prospective cohort, I give you another example of cohort. I worked in British Columbia Centers of Substance Use. It's ARISE. So ARISE cohort, it's a risk use study. It's a multiple-year study of street and wolf use being conducted by researchers in BC Center of Substance Use. Before it was BC Center for Excellence in HIV/AIDS. The study was established in 2005 and to explore individual, social, economic, and environmental factors that influence the health and well-being of street and wolf use in Vancouver. Through the interview, administrative surveys, and clinical visits, they based on when I took it from the website, you can read about those cohorts and more extensively on the BC Center of Substance Use website. What they published was 900 use. I think when I work on it, we had a little bit less. So this cohort is survey data. It's a snowball prospective cohort, but again, here you can use the data retrospectively as well. It depends where your baseline is. So if people can get into the study any year. But this is very important cohort because in addition to gathering person information, it also helps a lot of people. So for example, when they come to interview, it was set up very nicely that they can hang out together and get help, like if they need housing or anything or additional services and need break from the streets because they don't have where to live, they could come to a very safe and comfortable environment. And it's also, if they had any issue, it provided, there was a lot of like experts from different areas. It provided very confidential space for them to talk about their issues. And they provided optional STI testing if needed and provide information and consultation to community members, service providers, healthcare workers that involved in supporting youth who may have difficulty accessing health services or social services. So you can see the cohort study in health study, we sometimes using administrative data, but sometimes it's more just calculating incidence or calculating prevalence or calculating something we need. It's also looking of people experiences, and based on evaluation of people experiences, we actually can look for policy change. Yeah, so it's very important study. It's why I really like cohort study, because from classical design, from any other design of the study, you actually can do a lot, and you can change a lot in health and in community. If you study design correct, you develop survey correctly, you have right recruitment strategy, you establish, like for cohort study, such as ARISE, and there are other cohorts from Business Center on Substance Use. It's also important who you have in your recruitment offices, how they build relationship with those people, because those are vulnerable people, and it's really important for us not to lose them and want them to come back to talk to you. So for statistical analysis for cohort study, so one of main strengths of cohort study is the longitudinal nature of data, is the prospectively or retrospectively. Some of variables in the data will be time varying, and some may be time independent. So usually for any cohort study, you establish your baseline. Either you have baseline in one point of time or multiple point of time, like people can get into your cohort like in different time points. So usually whatever you measure at baseline, it will be your time independent covariates, but changes you're measuring over the time, it will be your time varying covariates or variables. And here I think what I wanted to say for both. So this is the error some people do when they do cohort studies. So when and I saw a lot of studies when this was an issue. When you have people asking questions on baseline, you usually ask about historical information. Did you ever inject drugs? Did you have some experience in the past? You don't ask when it happened, but you can ask specific questions about like childhood, for example, if you want to measure for ARISE cohort, if you want to measure childhood trauma. Yeah, different scales for childhood trauma. So you can ask it historically, but if you want current information and baseline, you can ask the same question like in the last month or in the 6 months. So if you structure your survey, if you have survey design and structures this way, you have both historical information and current information, and you compare. So after that, usually what had happened, you decide which questions you can ask same questions over the time to look on the temporal trend or change in people's behavior, but you also can introduce a new question. For example, you have follow-up survey today and you want to do new analysis or evaluate new policy, you can ask people new questions. And so this way your subsample will be only the people answer the specific question, but you can introduce new research over the time. For the cohorts that use administrative data, this will be not possible because you only get what you get and you work with who you can work. So for statistical analysis for cohort, we usually use an advanced modeling technique that usually include fixed effect and random effects. So if you remember, if you attended one of my first lectures about statistics, I talked about homozygosity and heterozygosity. So homozygosity, it's usually your mean, and heterozygosity, it's usually your variance. So when we're talking about fixed effects in the longitudinal modeling technique, we're usually talking about population level data that we're measuring with mean and maybe standard deviation. But when we're talking about random effects, we're actually looking how our recruitment or how our people are deviate from our population mean. So when we're using random effects, we actually incorporate an interperson variation because we follow the same person over a long period of time, and we are all different, and each person has their own behavior. So we want not only measure population level trends or population level incidents, we're also looking in those types of model for random effects. It can be different effects. You can run longitudinal model with random effects, or you can develop different covariates, different matrices for measuring individual effect and choose your best model, but I'm not going to go into details right now. So basically, usually The models you can do for fixed and random effects, it's mixed effect longitudinal model is a statistical approach used to analyze data collected over multiple time points or repeated measures on the same subject. Fixed effects, as I said, representing the population level trends, random effects capturing individual variability, and this model helps up to count and understand both overall pattern and variation pattern over the time. So the weakness of cohort study, it's very expensive to do cohort study. You need a lot of money for it. And it's time consuming because you need to develop your survey. You need to think about it. You need to continue in recruiting people, like if you're recruiting people in your cohort. And it's very hard to keep people in the study. It's usually very hard, very high dropout rate. Or you can have situation where someone was in your study for a long time, suddenly disappear and come back. You need to decide how you're going to analyze the data for those subjects. And if you have lots of follow-up in really high percentage, your results might be more biased. And you have selection bias. The initial selection bias of the cohort may introduce bias if it does not adequately represent the entire population. This could affect the generalizability of the study finding. So, for example, right now we're working on, you probably heard, for Women's Health Research Institute, we are looking in premenopause women study design as HER-BC. So we recruiting in different areas for women in specific age span, but it's really important for us to recruit people from different racial backgrounds, from different like urban area or rural area, because based on access to health and other characteristics, those people will be very different. So for example, if we recruit 100% from Vancouver because it's really easy, we cannot generalize our population for all BC population, only for people in Vancouver. So it's in all cohort, no matter what you do, you will have selection bias, and there is way in your future analysis from your modeling and descriptive analysis actually identify where this bias can lie, and you can do additional analysis for your paper or research to say we did maximum to ensure that we minimize our selection bias for the analysis. So the last one, and I need to talk very fast, it's experimental design. So experimental design is usually clinical trials. I also worked in Canada for 2 largest random assignment social experiments where it was related to education. So you still have element of random assignment, but it's not clinical trials. So for example, for one study, we randomly assigned over 5,000 people, and for another one, I think it was around 2,000 people. So it were like huge cohorts that were randomized. But for health research, it's usually clinical studies for new drugs or effect of drugs, or we want to compare drugs, or we would like to change some procedures and compare them. So usually we have element of dividing people based on the probability. So objective for experimental study design is aimed to establish cause and effect relationships through control manipulation of observation. Research methods involving manipulating of independent variables, observe the effect on dependent variables, and control for other factors to establish cause and effect relationship. Yeah, so basically in experimental study design, we have a lot of power. We decide what we're testing, how we're testing, how we assign people for each point of view. We know what you do. Of course, there is element of double-blind trial where no patient, no health administrator will know what they're administrating, but still you have very good control because people already randomly assigned. You have very good control of what you do. So here I put some picture of what phases of trial designs. Usually there is like different four phases of trial design. Unrestricted, when usually you decide about dosing or toxicity level. After that, it's safety and dosage, phase 1. After that, efficacy and side effects. And at phase 3, we're going to efficacy and monitoring of adverse reaction. And after that, when we're going to FDA review or other regulatory body review, we confirm the safety and efficacy. And after that, usually it may be on population level, we look at on long-term safety, surveillance, and efficacy. So in the last, it's usually was classical clinical trial phase design, but with COVID it's changed because due to the emergency, the vaccine developed did not go to all the phases. It went, I think, till based on the report I read, we went to phase 3 design, and after that, it's what was approved by the FDA under the emergency. Also, the clinical trials are changing. For example, with the introduction of precision medicine, there is no way for you to have control. Yeah. So basically, we're trying to allocate specific medication and treatment for specific person. So there is no element of control here. Or for cancer research, rarely cancer research trials will have controls, because a lot of clinical trials for cancer patients will be based on compassionate base. You ask him to do something to help people because there's nothing else you can do. So what is important for clinical trials? It's human-centric approach, prioritize, because we need to prioritize patient safety, autonomy, and ethical practices. And we need to involve the least exposure to potentially ineffective treatments. And so we need scientific precision. We need like very detailed study design. We need high statistical certainty. And we need to look at a lot of things to make our clinical trials working well, because at the end we need, if we develop a drug, and it's very important, when you developing new drug, it costs a company usually a lot of money. So you in the end wanted to be approved by a regulatory body to go out if it's safe and efficient, and all the stages of clinical trial design went as designed. So for randomized assignment, I'm going to talk about this briefly. There is like 3 major types of random assignment. At sample randomization, so basically it's like we throw in a coin and say 50% go to treatment group and 50% to control. There is broken randomization. It's kind of a simple sample randomization, but we want to allocate people in blocks. So for example, if we have 3 groups and we don't want to allocate them randomly by 33%, we say, oh, there is a high chance that we're going to lose treatment group, and we want to allocate 60% of the people to treatment group and 20 and 20 to control groups. In this case, we going to do blocks of people with specific number of people into it, usually like divided by 6 or divided by 8 or something like this common denominator, and you randomly assign people inside those blocks. And additional randomization and stratified randomization, I think we use it less in clinical trials, but in social experiments it can be done a lot, because if we have any prior information about the people, we can allocate them to treatment and control, or exposure, like they expose in social experiments, they will be exposed to some program or some change. So we can randomly assign them based on percentage. For example, we know census data for urban and rural. So when we stratify randomization, we can allocate people to the group. So it's very similar to stratified frequency allocation for case control study. So this is my summary slide, basically it shows the differences between experimental and observational study designs, and the major difference between those, it's internal and external validity. So internal validity is the extent to which you can be confident that the cause and effect relationship is established. So we only can reach high internal validity with randomized trial, with clinical trials or randomized trial. But there is the external validity. It's basically how we can generalize our finding to general population on other populations. So if you look on all those studies from perspective of internal and external validity, clinical trials will have, or random assignment experiments will have very high internal validity, but low to moderate external validity, and all observational studies actually will be opposite. So to summarize, I know I didn't talk a lot about different statistical modeling, but I think for case control, for the cross-sectional study, I actually put it on the slide, but it's basically basic descriptive statistic or any one-point modeling, like logistic regression or proportional Cox model if you're doing survival analysis. But cohort study will have more sophisticated application, statistical application. And like we need to define properly the study design in order to see which statistical and analytical tools we're going to use to analyze his data. And understanding study design will help us to get, I think, better research and better results and better experience for patients if we're going to do it very rigorously and we actually understand what we want to get and how we get there. This is all. Thank you. Do you have any questions? No questions? So for the next lecture, I didn't decide, but probably it was like additional more basic statistical lecture. I'm going to talk about different tests, like parametric tests, not parametric tests. If you're interested, I think in one of our e-blasts, I wrote two newsletters. I think one was for August and another September or September, October. I don't remember. I talked about appropriate test for continuous and categorical variables. So you can read it if you want. It's like a lot of tables and everything like summarized very nicely in a couple of pages. But I'm going to give some more examples in the next lecture. And after that, we're going to go for more sophisticated areas of statistics, such as different types of modeling, from simple modeling, although it's not so simple, from linear logistic regression to more sophisticated survival analysis, and maybe I touch a little bit about longitudinal studies as well. Thank you. And as you noted, we changed the Zoom link for this series. So from now on, the new link will be available in all our social media, and also Eventbrite invitation will have the correct link. Thank you and have a nice day. Bye.